We now move ahead to the next keynote address, which is on the topic EECP and CBD Protection 2012 and beyond. Our speaker this afternoon is Dr. Bindukumar Kansupada from United States of America. Before the chairpersons invite him to deliver the lecture, may I invite Drs. Manish Bansal from India and Arun State from United States of America. They'll be joined by Dr. H.K. Chopra, and Dr. Kansupada would have 15 minutes and 3 minutes for the address formalities, and since this is a keynote address, we will not be having any questions from the floor. It's over to the chair.
Ladies and gentlemen, I've just shown you 3D data before and after ECP. ECP is a very, very powerful tool in the wellness clinic in the United States. And I'm presenting to you a very, very important person who is basically an interventional cardiologist, Bindukumar Kansupada, who has a lot of contribution in the cath labs, but now he's scared recently of radiation injury which is caused to the cardiologist. So he's changed, there is a paradigm shift. He's gone to more of a heart wellness and not in the heart illness. Let's see what he has to say. The subject he's going to cover is EECP and CBD Protection 2012 and beyond. Ladies and gentlemen, I present to you Dr. Bindukumar Kansupada. Kansupada, sir.
Thank you very much, Dr. Chopra. Thank you very much for inviting us. I feel so blessed by Didi and already has been experiencing bliss. We are going to talk today about interesting subject which we all face in day-to-day life. And I have a question for a lot of you sitting here. How many of you are interventionalists? Okay, and how many are surgeon? Good. I think we are going to start moving, and I think we'll start talking about some of the day-to-day which we all experience in our daily clinical practice, which in my experience, we are a group of 11 doctors, and we do around 1,000 plus for intervention. Okay. And what I want to talk about is real patients which we come across, and this is one of my multi-millionaire Indian patient who is 56 years old, diabetic, had a documented triple vessel coronary disease, diffuse vessel, distal vessels are 1 millimeter size, ejection fraction is well preserved. He continues to get 3 to 4 episodes of angina per day on walking less than 200 to 500 feet per day. Fortunately, his angina doesn't last for more than 5 to 10 minutes. His consumption of nitroglycerin per day are 3 to 4. So he goes to multiple physicians and he comes for second opinion. What should you do on him? Incidentally, he already gives you perfect medical history. He's on optical medical therapy. He's on beta blocker. He's on statin. He's on dual antiplatelet agent. He's on ACE inhibitor. And his complaints are really increasing angina with minimal activities, fatigue. So he's frustrated. He said, I got a lot of money, but what do I do? What are the treatment options we offer to this guy? Do we experience this on day-to-day basis? Yes or no? And what do you offer to them? This is the condition which we all experience, we call refractory angina. And as we know, incidence and prevalence is increasing all over the world. And I want to share some data with you in the United States and then India. In the United States, right now around 50,000 people are diagnosed with refractory angina per year. And the total population is somewhere between 600,000 and 1.8 million. India, as Dr. Chopra mentioned this morning, is on the course of taking over the rest of the world for the epidemic capital of CAD. And 5% of population has refractory angina among the CAD population. So I think what is important is to look at the next slide, which I'm going to address about. We all are used to think about preventing the complication. And when we went to med school, we all thought about fixed disease, 70% or more, and treat it, fix it, do the revascularization, we are done. Now the new paradigm shift is thinking about neurohormonal changes and other factors, metabolic factors and pro-inflammatory markers we measure and change the whole modulation of therapy. The new treatments which are available as of today are ECP, electrical nerve stimulation, laser revascularization, shock wave therapy, percutaneous venous arterialization, stem cell therapy and gene therapy. Out of this, 2 non-invasive therapy available in all over the world is ECP and shock wave therapy. As of now, shock wave therapy is not approved in USA, but ECP has been used from 1995. Dr. Haryawala will mention the 2 last therapy which I want to mention. They are very promising. There are more than at least 9 studies which I am familiar with. They are very, very encouraging, and stem cell therapy and gene therapy might alter the course of this refractory angina and people who have good prognosis but lot of suffering. Other debilitating condition in the United States and India is going to be heart failure, which we all experience day to day. Roughly, approximately 6 million people are diagnosed with systolic and diastolic heart failure in USA. 2 million new cases are diagnosed per year, and death with heart failure is approximately 275,000. In America, heart failure is one of the leading cause of expense for the government. Refractory angina, as I told you about, data is and the cases are increasing every year. The real fact about refractory angina is they don't die quickly. Mortality is less than 5%, but unfortunately they suffer a lot. They have debilitating angina. And the reason they don't die quickly is because their left ventricular ejection fraction is preserved and they don't experience ventricular arrhythmias. This is something interesting which I found it out talking to some of our colleagues from here as we talked about exchange of data and experience. Cardiovascular disease in India is on tremendous incremental prevalence. As were expected by WHO and the Indian Medical Council, cases are going to be increased in next 4 years by almost 2 to 3 times, up to 60 million new diagnosed with CAD. Deaths will double up, and obviously with that, prevalence of refractory angina will increase. So we need to offer something to this patient who are suffering. We don't have as of now the data on ECP for mortality morbidity improvement, but patient wants to get some alternative therapy so they can do their day-to-day task. So I'm going to touch the basis of what is ECP, how do we function, how many patients benefit, and let's see what it comes next. Certain thing which I was impressed by some of the presentations by our speakers today, and Dr. Enas has done a lot of data amongst Indian and Asian male especially. The MI occurs in Indian male at much younger age, around 35. They are known to have small vessel diffuse triple vessel disease, and there is surprisingly higher incidence among female in USA for Indian population. I don't know about India, but that's certainly a fact which we have noticed. ECP in India, according to what I got the data, there are more than 50 centers are already in India, so people have experienced some benefits of ECP therapy. This is non-invasive therapy as we talked about. It requires multiple sessions, 1 hour treatment, 5 days a week for minimum 7 weeks, you get maximum benefit. And this is the cartoon which display how comfortable patient is and how it can be done in outpatient setting. Now the principal operations are very simple. As we all know as interventionalists, the coronaries require blood flow in diastole. If you improve the diastolic coronary augmentation and if you improve the cardiac output, patient's symptoms are going to be abated somewhat. This is the slide which is not functioning, so I'm going to let it go. We tried and that's what we got stuck a little bit. Who are the patients who are going to benefit the ECP? Clinical indication right now approved in the United States, but it is going to be applied all over the world, are the Canadian class 2 and 3 and New York heart failure classification 3 and 4 more so. Now these are the people who experience the symptom with minimal activities. Now some of the things which we have to be careful when we prescribe the ECP, we want to make sure that certain people do not get enrolled for ECP. Number one is severe aortic insufficiency, malignant arrhythmias, bleeding diathesis, especially people with PTIN of more than 3, and pregnancy and aortic aneurysm. ECP is an interesting concept for the mechanism of action. Is most of us we talked about is it improves the angiogenesis, it improves the collateral blood supply, and it also decreases the pro-inflammatory markers. Some of them have been measured by different studies, although not a very large population study, but it has been measured by such a marker as cytokinins, VEGF, etc. I'm not going to go into details with all this data, but it certainly has been measured. Mechanism of action is, as you can see, systolic unloading is a prime factor. It also affects the shear stress, which leads to vasculogenesis, improves the endothelial dysfunction, and diastolic augmentation. As one of this, which you can see, person has circumflex artery stenosis, it gets so much of benefit, symptomatic relief of the symptoms. His vessels were very small size. Most important aspect is what we call indirect measurement by nitric oxide, which has been measured. Interesting aspect is some of the small studies which they were able to measure, and the effect lasted at least up to 3 months on this nitric oxide measurements. Endothelial dysfunction, as most of us have been talking about, is a big factor for plaque rupture. And if we can alter that endothelial dysfunction, I think people are going to feel significantly better. This is one of the invasive measurements which they did it on less than 30 patients, 2-to-1 segmentation. A sham study, sham group had 7 and the other one had double the amount. And they show that fractional flow reserve improved significantly, and the pressure-derived collateral flow also improved. So direct and indirect measurements were already done in small segment. The clinical benefits of ECP, most of us we know that what we want to measure and what we want to feel. We want to improve the exercise tolerance time. We want to decrease the angina threshold. We want to decrease the consumption of nitroglycerin. We want to decrease the heart rate. They all have been done. Indirect measurements were ANP measurement, BNP measurements, VEGF measurement, and the clinical aspect what we measure is cardiovascular Canadian class measurement, which in a lot of study they improved at least by 1 class in 73% of patients, which I think was beneficial to a lot of our patient population. The 2 large study I want to touch briefly is one study was done in 1993 by one of my classmates, and that was multi-center study called MUST, and the end results were what they were able to see versus the sham group. In the ECP group, people improved angina threshold, nitroglycerin requirement, and the time to exercise-induced ischemia was improved by 37 seconds. That was the significant beginning of benefit of ECP. And the next study which I want to address is, after this one, is if you can see this slide, which I'm a nuclear cardiologist, so I want you to demonstrate that pre-ECP, if you can see the anteroseptal segment had a significant effect. As you can see in post-ECP, that area, anteroseptal area, lights up. Mind you, not every patient benefit. Only 2/3 patients are going to benefit. 1/3 does not get 100% benefit. 11% have some benefit, 22% no benefit. But it's still better than nothing. And PEACE study was another one which I want to allude to you, was the heart failure data, which shows that majority of patients benefited, 1/4, I shouldn't say majority, but they did benefit by fatigue symptoms were improved. And their exercise duration was improved by more than 60 seconds. Mind you, this peak VO2 measurement did not really change in a lot of patients, but seniors above 75, they benefited a lot. Another study which I want to touch in last 30 seconds is international registry, which a lot of people were there, roughly 7,000 patients. But the important is 86% of people in class 3 and 4, which they have improved at least by one class. As you can see, 25% people had benefited, 35% have hardly any angina. So I think that's some benefit versus no benefit with other modalities. This patient was followed up to 2 years, and as you can see, it showed a lot of benefit. One more thing I want to show. I'm glad I'm done. If you have a question, I'll answer them. But important aspect is number of ER visits and the frequency of hospitalization was significantly reduced up to 6 months. And I need to say one thing clearly. I was trying to look at the data for mortality, morbidity, then none. But benefits for clinical experience, how patient feels, that is ultimately patient wants to feel better, they want to improve the quality of life, and they want to be functional. So I think when there are no options available to some of our patients at young age or old age, I think that option is there. Shockwave therapy is another option which is available. I think we need to get more data on both the modalities in the future, but I'll be more than glad to take any questions if anybody has it.
Thank you very much, Bindu.
Already there are infected, dead myocardium. So you should transfer to Dr. Hariawala to do a stem cell therapy. So even if you do 25 sitting, 30 sitting, it will not improve. So what you correctly showed one of the slides, few slides that pre-EECP. But in my opinion, in every patient of EECP having a diffuse disease with a multiple vessel disease, first a baseline myocardial perfusion scan should be done to select the patient for EECP.
Absolutely great question, and I would totally agree. What we do is all these patients, when they come to us, they have gone through that diagnostic nucleus test, followed by chorangiography. They have taken multiple opinions, then optimal medical therapy, and in spite of that, they are experiencing at least 3 episodes of angina per day on walking less than quarter mile. That is what we see most of our patients who are young, preserved ejection fraction, and positive viable myocardial perfusion scan. Usually we do chemical nucleus tests.
I think it's very important because Bindu just gave a comment that it's a option for no options. I agree with that.
Yeah, absolutely,
but,
you said.
Yeah,
correctly.
but that is not only the indication. We have patients even with a grade 2 angina or patient having a mild LV dysfunction, as I shown you in my data of a HFnF, grade 2 or grade 3 LV diastolic dysfunction, they reverse completely. And I think there is a huge data coming up. I have a series of patients in stroke. I have a series of patients in microvascular CAD. There is a huge data. I've already submitted my paper for circulation. There is a huge data coming up with the ECP intervention. I think we all need to have our pilot observational data and create a double-blind randomized trials with perfusion, without perfusion. Everybody does not need to go for a nuclear scan at all. We are echo people. We subject all our patients for echo evaluation, and we have enough information. And we show the reversibility and regressibility by this intervention. It's a huge data, and it is an adjuvant to the medical treatment. I think it is one of the very crucial and important part in the setting of a stroke ECP and then a CVD regression ECP program. And a time is going to come, we are going to do in the impotencies. Dr. Kapoor is here or not, KK Kapoor, I don't know, I'm going to do some protocol with him. And peripheral vascular disease, there is a huge data on this. Kapoor is doing a lot of work on this. Manish, what are your comments on this? Manish is doing a lot of work in Vedanta Med City. They were the first people in India. Ravi Kasliwal and group was the first person 10-15 years ago. They started ECP in heart failures. And Sanjay Mittal was the another guy. I'd like to have his comments.
I think it was a very elegant presentation on the utility of ECP in patients with CAD. As we know, India is diabetes capital of the world, and diabetes is notorious to cause diffuse disease. And Indian population is also aging, so we have now more and more elderly people who have got diffuse disease, who have already had 1 or 2 bypasses and angioplasty. So there is a huge chunk of population who could be benefited from EECP. But in India, I think another important aspect is to have some kind of regulation to prevent indiscriminate use of the technology, because that is something which is common here, and indiscriminate use can kill this wonderful modality for patients who otherwise have not much option for treatment.
Ladies and gentlemen, may I now request our chairpersons, Dr. Chopra, to kindly present a medallion and a scroll. I'd request Dr. Seth and Dr. Manish Bansal to also kindly join him for the presentation ceremony. Dr. Seth, if you could please join with Dr. Bansal. Thank you very much, gentlemen, for being part of the presentation ceremony, and Dr. Bindukumar Kansupada for delivering this keynote address.